Hello everyone, good morning, good evening, wherever you are joining us from. Thank you all for joining our webinar. This webinar today is our second webinar in our special series of webinars that address the challenge of managing a safe laparoscopic closure under the new IFCS guidance. Gaudier surgical innovation, the True Close, a novel two-in-one closure device that provides a new way for surgeons to approach laparoscopic port site deficit closures, especially with obese patients that may be more challenging. New protocols in the OR may vary from small changes to large changes following the new IFSCS guidance. Following Dr. Ugale's presentation, we will address your questions. Please send us your questions here at the Q&A icon below. I am honored to introduce Dr. Surendra Ugale. Dr. Ugale is the Director Department of Bariatric and Metabolic Surgery at Kirloskar and Virenci Hospitals, Heidelberg, visiting Professor of Surgery at KLE University. He has been passionate about laparoscopic surgery since 1991, spreading it to many parts of India and abroad. His team is the second in the world to start laparoscopic ileal interposition for type 2 diabetes in 2008. Then trained surgeons in Turkey, Georgia, Iran, and Mexico, and other places around the world. He also introduced a new scoring system, Diabetes Severity and Remission Score. His work is now especially focused on metabolic surgery for diabetes and obesity, and he is a proctor at national and international centers. Dr. Ugale, please, the stage is yours.
Well, thank you very much for this kind introduction, Amit. And my greetings to everyone, all our colleagues from wherever you are in the world who have joined us for this. This is a subject which I have been involved in the work in the clinical trial. And I'm happy to be able to present this because it's something that I enjoyed and I liked using. And I think it's something that will help all of us. So have a look at it objectively, see how it suits your field of work, and make use of something that you find useful. So let me get started. I'm going to start sharing my screen and make a presentation to you and then take in the questions later. So, so this is the two-in-one solution for port closures, as we say. We all in laparoscopic surgery have to do port closures, because we know that if you don't do port closures, there is a generalized worldwide incidence of 0.75% of hernias from the ports. And if you look at bariatric surgery per se, the incidence of hernias is about 0.5%. So when you've done a good surgery and everything's over, you don't want after a few months to have a hernia and the patient be troubled by it and then you have to deal with it. So we are happy that Gordian Surgical from Israel, they came out with this nice biomedical and technological innovation, which we say is safe, simple, and secure. And as we said, what if we have a device which right in the beginning of the procedure, you have an automated closure, which will not require you to have visualization and insufflation at the end, because now in these COVID times, we all the more want to be careful about it. And that's how we give a safe environment for all healthcare providers. This is whether we believe or not that the air in the operating room may have any of the virus during a desufflation or instrument exchange. And also the issue of a automated capture of the tissue, because there's a variable amount of tissue capture when you use a suture passer. So port closure is important, not always easy, because remember we, at least the senior surgeons in all teams by this time are out of the OR, and the younger junior surgeons are closing at the end most times. So one is the manual way of closures, where you take your needle holder, you take your artery forceps, or you take a small retractor and you're trying to get the edges of the wound. In obese patients, it obviously is a problem. It's cumbersome, and you need direct visualization if you don't want to pick up momentum or the bowel and create any problem later. Now, the devices that we have for closure, they all require insufflation visualization. I'm not saying it's a very high-tech issue. It's done very simply by many surgeons, but yes, you need a separate suture material, and you need a separate instrument with which is a suture passer, which are available of different types. Many of them are sharp, and sometimes they cause a bleed in the wound, and so you have to be careful where it is inserted. Now, when you, at the end of the procedure, you take a usual suture with a knot and a closure with the suture passer. The typical closure, the full loop knot. When you look at how it is with the instrument that we are showing you, you get what is known as a half loop knot with this instrument, which is known as the troclose. So closing at the end of a procedure with any suture passer requires the direct visualization and insufflation. The tension on the tissues is 75% greater, and this can contribute to more pain in the wound. So obviously we always wanted to have something, and wouldn't all of us as laparoscopic surgeons want something that is easier and safer? So instead of having a variability, instead of having uncertainty of how much of tissue, do you have enough of tissue, or do you have less amount of tissue? So will you get a good closure or not? Plus an issue, and I've actually seen this in an operating room in New York, believe it or not, and it's probably, it could happen anywhere, that at the end, the suture passer, while being used, the tip of it broke, and they spent about 1 hour with an image intensifier trying to locate that tip to retrieve it and bring it out. So you see, there are so many little issues which we may be able to overcome. Also important to know what is in the surgical smoke, because now with in our times right now with the stresses of the COVID infection, besides all the particles in the smoke, we also are worried about the virus being in the air. So that's another thing which is a guidance from many of the societies, that during desufflation, during specimen removal, be careful of how much of the peritoneum or the smoke is, intraperitoneal smoke is let out in the operating room. So the air leak risks which happen during surgery, they come with during trocar insertion, when the air can leak out, with every instrument exchange. These are usually all small. We have to guard when there is a specimen removal. That is an important aspect. And then there is desufflation at the end of the procedure. So there are various expensive filters and evacuation systems which are available. In India, we also use some less expensive systems, like a tube which is linked with that, with the underwater seal, and we at desufflation we let the gas go through into the tube into the underwater seal, so that there's no leakage into the operating room. And port closure is required for all ports which are 10 millimeters or 12 millimeters, or when we are using other types, some types of staplers, we may need 15 millimeter ports. Now, these are some of the SAGE's guidelines regarding the COVID times and the practical measures for laparoscopy, where it is advised that incisions for the port should be as small as possible to allow passage of just the ports, but not allow leakage all the while when the procedure is on from around the port. Carbon dioxide insufflation pressure should be kept to a minimum so that you don't get all those extra leaks, you don't get high pressure leakage of gas into the operating room, and usage of ultrafiltration systems as and when available and advised. And all pneumoperitoneum should be safely evacuated via a filtration system before the closure and before the removal of the trocars. And during the specimen extraction, you have to be careful. So complying with all these things, we are trying to make life easier with a special instrument that has been created for this, where without having to worry about how much, whether you've got the right amount of tissue or not, an automated closure system is placed right in the beginning of your procedure. As I mentioned earlier, doesn't require visualization and insufflation at the end. So it's safe for the environment, minimum amount of pain, if at all, definitely much less pain than the full loop system, which we normally do. And the capture of the tissue is very precise, equal on either sides, without the use of these sharp suture passers. So here's a video to show you and how the instrument looks. That's the trocar and cannula, which is loaded. It is passed in just like any other trocar and cannula. That's the loading of it. It clicks into place from the sides, you can see. Goes through the abdominal wall, and then you have to hitch it back. There you can see the animation, you hitch it back so that the cannula is out of the abdomen, and then you arm the trocar. There you can see it being pulled up. It is armed, and then when you press it down, it fires the anchors through the abdominal wall. And you can see those are those plastic looking anchors on either side. And then you can remove the trocar, do your procedure. So that's how it looks. It stays there. Now when the trocar is removed, your cannula is there just like any other cannula. And you can see the absorbable anchors which are in place. And then you do your regular procedure, whatever operation you're doing. This was one of the bariatric procedures over here. And at the end of the procedure, you have to remove your cannula. There you can see how the cannula is being pulled out and the threads are left over there. And then you just have to tie the threads in place. And you can see those anchors in place and how this becomes a half loop knot. It's not a complete entrapment of tissue, so the pain is much less in those areas. And those anchors are made, the sutures and the anchors are like Vicryl, polyglycolic acid. That is the Gordian Surgical Stroke Close 1200 system. The one which was shown was the 12 millimeter. They are in the process of making ones for 15, and in place of the 10 millimeters, which many times we use for insertion of the laparoscope, you can use the 12 over there too. So what we suggested in the beginning, maybe once or twice, you can be under vision on one side and do an insertion that helps in the learning process. And then you understand exactly how the feel is and when to fire the anchors. And then later you can use it for your first port and your second port, and you have a beautiful trocar cannula for the full surgery with a port closure. So as you can see here, these are absorbable sutures. It's a 10 Vicryl polyglycolic acid type material. It's absorbable, and the anchors are made of polyglycolic acid too, and the tip is bladeless. So the half loop system, anchors deployed, trocar anchors, and the trochlose anchors are not sharp, so no trauma to any of the blood vessel or the tissue there. And the port side gap closure is placed in the beginning and completed tied at the end. So especially in these times, even more important, and I would say going along with all the guidance of all societies to be careful with the OR pneumoperitoneum gas. But I'm saying even at other times, won't you be happy if you have a smooth, beautiful trocar cannula insertion with the placement of the sutures and the anchors, and at the end you just have to tie it, and you don't have to worry about looking at things at the end. So this is the publication that that came out in the Journal of Endocrinology and Metabolic Research, and it shows the experience with all the clinical trials where 50 patients underwent procedures using the trochlose system. There were no port side hernias at all, with a 1-year follow-up after bariatric procedures also. And there were no serious adverse effects. There were no major trauma or problem. And the ease of deployment as marked by all the users was very good. So I think it's a very positive instrument, something that, as we say, if you can travel in business class in the airline, I mean, would you choose the business class or economy class? And if the cost of that is similar, then why would you not use something that is beautiful, easy, comfortable? And what is coming future is trochlose is making a 15 millimeter port closure system. They're going to make an optical obturator also, and a disposable kit for robotic surgery. So they are working on these, and I, for one, have been extremely happy with this. As a disclosure, as I sent to some of my friends, which instead of saying at the beginning, maybe I can say it at the end, that I was part of the clinical trial, but I don't have any financial arrangements or anything with trochlose. And it is my pleasure because I've been associated with them and I believed in the equipment, which is why I thought it would be nice to be able to share these experiences with everyone all over the world. And with that, I end my formal talk, and based on your questions, I will take, I have a few more slides if anyone wants to see the actual parts of the instrument in little more detail. So I can show that if anybody asks for it or wants to see it. So thank you very much for joining, and I'm happy to take any of the questions. Thank you.
Thank you very much, Dr. Ugale. If you have a question, please, again, write it down at the Q&A link below. We have one question, Dr. Ugale.
Yes.
The question is, at times you have to withdraw the trocar for specimen delivery, or it may accidentally slip out. Can we reintroduce the same trocar or use another one?
Oh, this is from Dr. Abhay Agarwal, a colleague from Mumbai. Yeah, thanks for the question. You can introduce the same trocar which has been introduced in, but if you remove the cannula, then the sutures will be let free, and actually keeping the sutures aside, you could even reinsert the same trocar and cannula inside, and for any visualization, and at the end again you can come out. So yes, you can.
We have a few more questions.
Okay, I can see. Yeah, sorry to interrupt you, Amit, but I can see a president of OSSI, Aussie in India, Dr. Khaitan, Manish Khaitan has asked this question. Does it easily take any of the stapler guns, whether it's Medtronics or Johnson and Johnson, and what is the price? So it takes all the guns, yes, and yeah, for the 15 millimeter cartridge of Medtronics, Troclose doesn't yet have a 15 millimeter, but they are making one very soon. So when that is out, then each and every type of cartridge will go through. The price, depending on which part of the world we are in, because there are different issues with the customs and government regulations and local issues, but the price ranges somewhere between 55 euros to 75 euros. So I think when I also tried to compare the pricing and to see with what we have and what we use right now, and to me it seemed like a very good alternative, because then we don't need an additional suture and a trocar and a suture pass at the end, and with the added safety advantage, I thought this was a great price to have. Then we have a question from Dr. Rui Ribeiro from Lisbon, Portugal. Glad to have you, Rui, with us. His question is how to proceed with the first trocar. Yes, so as I mentioned earlier, maybe for the first case or second case, maybe it would be good to use it as your second trocar. Get your laparoscope in with the first one like you normally do. And when you take your stapler port inside, you can use this. So you can actually see it functioning slowly. You can understand it. And once you get that feel, then you know when to fire that the anchors in place. So probably from the second case itself or the third case onwards, you definitely can use it for your first trocar also. So the trick is, once you enter, when you feel the give in, I mean, this is until we don't have the actual the visual port from Troclose, which they will bring out later. But until then, once you go in and you feel the tip has gone in, after that, you need to draw it backwards so it abuts against the abdominal wall. And that is where you arm the trocar and then you fire it so that the anchors get released. And then you push it in and your cannula goes in. So that's how you use it for the first trocar. Then to take the next question, this is from Dr. Giuseppe Zilli. And he says, hi, what is the first tips and tricks you would give to a new user of the device? Yes, so as I mentioned, I would suggest that you use the first and maybe the second time as the second port so that you can visualize it and see it from the side. But and if you're using it as a first port, once you've gone in blind, you can feel the trocar going in with the giveaway, then hitch it back, fire the anchors, and then go in with the cannula, then remove your trocar. So that would be the way. And then Zvi has asked, what are the anchors made from? So the anchors are made from PLGA, that's polyglycolic acid, and it's a Vicryl-like substance. This has a strength which keeps it strong for 3 months, and so that should give enough of strength for the duration of the placement, so that you don't get any port site hernias later. And just to I think I've answered the questions which existed so far. So let me see if there are any more questions. Yes, so far these are the questions. There's one more. No more questions so far. So Amit, is there anything else you want to add, or if anybody has any more questions, please go ahead and ask while we are online. Dr. Sagu from New Delhi, yeah, thank you for joining. He says, When will it be? He says it seems to be a good alternative. Thank you. And Gordian will be happy to see that. Manoj Barucha is asking, when will it be available? So, Amit, do you want to answer that question? When will it be available in India?
Yeah, thank you for the question. We are in a process of regulation in India. The product will be available when we will finish the regulation. We are working with some distributors for India. So I hope to finish the registration as soon as possible, and then it will be available.
Okay, and Dr. Sagu from Delhi, he says he is convinced about it. Well, glad to hear that. Well, I mean, since you all know me, I can assure you, since I believe in the instrument, I can tell you very sincerely, it's a beautiful, smooth instrument, fires well, gives you very good safety profile, and I've never had a problem when I used it for all the patients where I had used. Then we have Dr. Anand, who says, any misfire, or do you have to use another one during surgery? Dr. Anand, suppose you have gone, say, instead of firing at the point when just your trocar tip is inside, suppose you've gone in fully and then fired it, it'll just be lying loosely in the abdomen. So if you have any sort of a misfire, then we can't retrieve it back after it has fired. And so you will have to use another one. But believe me, it's a very simple instrument to use, and I'm sure that whoever wants to use, when they use it for the first time, somebody will show them how to do it. And I'm sure in some of our workshops in India and abroad, or now that we are so much on all these Zoom meetings and online, we might be having many opportunities to use it in maybe some light surgery and showing it. So it's very simple to use. There's practically no learning curve. So I don't think you should have a misfire in anything. Then we have a few more. Dr. Soteben is asking, is there a risk that the anchor could hook up? Example, hernia meshes post-operatively. Are you asking whether it'll cause a problem for a hernia mesh that is already in place, or in future you'll put a hernia mesh? If you, okay, hernia that's already in place. So if you have a hernia mesh already in place, now this honestly will go just like a regular trocar and cannula, which at times we go through previous hernia mesh sites also. If you do have to go through the mesh site, this will behave just like a regular trocar and cannula. The anchors have got enough of an action. It's because when it's fired, it fires in beautifully and smoothly and very rapidly, as you saw from my demonstration. And so it will go through without getting entangled. So there won't be any problem with that. Then we have Dr. Luciano Innocenti asking, which is a trocar site with more hernia complications? Well, trocar sites that we use, like a 10 millimeter or a 12 millimeter, either in the umbilicus or anywhere in the lower abdomens, you get usually more hernias. If it's in the upper abdomen, you still get hernias. So any trocar site which is 10 millimeters or 12 or 15 can have a hernia problem. So this would be useful for closures of all this. Then Dr. Nisim, glad to have him. Oh yeah, he's answering the anchors. Oh, he's saying the anchors will not go through the mesh, is his opinion. But these, I'm not talking of a fresh mesh, Dr. Nisim. Please tell me whether you agree or not. We are talking of a mesh that is already in place, operated some time back, which is part of the abdominal wall. Now it behaves like the abdominal wall. So I would expect it to go through any sort of abdominal wall. Please correct me if I'm wrong. If anybody else has got greater experience than that, please correct me. Then Dr. Sagu is asking, can this be used in TEP as well for the anterior sheath? In TEP, but in TEP you don't, I mean, fire anything. You're not having a large space of vision from other sides, right, Dr. Sagu? So I would suggest you don't use it for a TEP. It's easier in a TEP to just close the sheath if you want to. If the rectus muscles are there underneath, most times, honestly, we don't close the sheath. But if it is big, then yes. If you see a gape, then you can just take a suture. But this may not be an appropriate site for usage of this. Then Dr. Avinash Tank is asking, he's saying we missed the initial demonstration due to connectivity tissue. Okay, so we can repeat the demo, sure. Dr. Nissim has clarified that it is not sharp and will not pass through the mesh. We know it for sure. Okay. So I respect your experience and opinion, Dr. Nissim. Was it to do with a particular type of mesh? Because in the same way as we use a suture passers at the end of surgery, when we don't have this sort of an instrument, we have used a suture passer, and it has taken the suture and the suture passer through the mesh, which is why I said this. But if you have a different experience, then we respect that, but maybe it is with a particular type of mesh. Please clarify that in your message, then I can share it with others. Dr. Hema is asking, could you please share a contact number or email? And yes, we will send you, or Amit will send you. I will pass on your contact to Amit, and he will send you the email address and the contact number for Gordian Surgical. Sure. So that's answering whatever questions and comments we had so far. Amit, anything else you want to say, or does we want to add anything? Does Dr. Nissim want to say something? Because, okay, Dr. Nissim is sharing further. He says the tissue passer is sharp, but the anchors are not. Okay, that was earlier, was it? Okay. So, fine. So, if you feel then we shouldn't use it through the mesh, then maybe one can keep a guard of that. I think that was Dr. who asked us about the mesh. Was it Dr. Sotebin? Yeah, who asked us about the mesh. So please be careful with the mesh. Again, a point to Dr. Nissim. Is this an early experience after the mesh? So I don't know. I still am very positive about it, but maybe then if there's a mesh, we should guard against that, or take a port site which is away from the mesh area. That would be the way to go there. Any other pointers? Let me see. Dr. Sotobin, I think the point is that we need to avoid access through the mesh. Yeah, I mean, usually when we know we can avoid that, yes. On few occasions, when say some sort of a mesh has been placed that is covering a huge area of the abdomen, we actually go through the mesh. But of course, we use a sharp trocar and cannulae. So if you know there's a mesh in a certain area, and if you have alternate sites, definitely please take the alternate site. completely respect that. Dr. Hema, she says, thank you for sharing this, interesting and useful. Yeah, thanks very much for having joined us for that. We appreciate your comments and we'll get all this. Rui says, thanks. Issue, the internal diameter of the 12 millimeter trocar, because of 3D cameras don't fit all trocars. Okay, so this 12 millimeter trocar easily takes in all our staplers of J&J and of Medtronics, which are with the purple or the blue cartridges, etc. So, so Rui, I would say that your 3D camera should fit easily through this cannula. That should not be a problem. So Amit, any other pointers you have? Any other things anyone wants to make clear? Amit, any other words from you?
No, thank you very much, Dr. Ugale, for the presentation. I would like to share with you all my screen with the details, with our details. So you will have it. Thank you again, Dr. Ugale. If you would like to receive future updates from Gordian, please follow our LinkedIn page. We would love to hear from you. We really appreciate your input, your interest, and your recommendation. I would like to thank you all again. If you have more questions, please contact me directly through my email address or my phone. Thank you very much, all of you, and all the best. Dr. Ugale, thank you very much again.
Yeah, my pleasure. Did you see there's one more point in the question answer? Just make sure you're not missing anything. Okay, Dr. Soterbin says, thank you very much for a nice presentation from Switzerland. I thank you, Dr. Soterbin, our pleasure, and we were glad to have you. So yes, Amit, if all questions are answered and everyone's seen what they wanted to see, well, thank you for organizing and hosting all this. I'm happy we could share it with all the surgeons who are interested, and it's something, as I said, would make life easier for us. So we look forward to having this in our practice. Thanks so much.
Thank you very much. All the best to all of you.
Thank
Bye-bye.
you. Thank you. Bye. Bye.